The opinions expressed on this program represent the viewpoints of individual authors or contributors and do not necessarily reflect those of Troy University. This is EconVersations, a joint production of Troy Trojan Vision and the Manuel Johnson Center for Political Economy. Now, here's your host, Dr. Dan Sutter.
Hello and welcome to EconVersations. I'm your host, Dr. Dan Sutter of the Johnson Center for Political Economy at Troy University. Alabama has a documented shortage of medical professionals in rural areas, and these shortages are linked to poor health outcomes for our residents. One way to address these shortages might be to expand Medicaid and spend more tax dollars on health care. Another alternative is deregulation, removing two types of regulations Alabama imposes on our healthcare system, which restrict the supply of lower-cost healthcare, particularly in rural areas. These are known as Certificate of Need and Scope of Practice regulations. What do they involve? What are the rationales for them? And what does the evidence show about their impacts on healthcare? Joining me on EconVersations are two economists who have examined these regulations. Dr. David Mitchell is a distinguished professor of political economy at Ball State University, where he directs the Institute for the Study of Free Enterprise. Dr. Mitchell has published dozens of papers in the areas of public choice and also health economics. Mr. Macy Scheck is a doctoral candidate in economics at Middle Tennessee State University and a fellow with MTSU's Political Economy Research Institute, which is directed by our former Troy professor and my former colleague, Dan Smith. Welcome to EconVersations, gentlemen.
Hi, thank you. Thanks. You.
So let's get started here. And if you could, briefly, each of you, Macy, you're going to talk about Certificate of Needs, and Mitch, you're going to be talking about scope of practice. So Macy, start off by telling us briefly just what it is that this Certificate of Need is about.
So, Certificate of Need, I may reference it, or Dr. Mitchell here, or you, myself, or all of us included may reference it as CON going forward. Not pros and cons, CON being Certificate of Need. But really, it's speaking to this regulatory mechanism for the state to try to control expenditures on certain healthcare facilities, or even the operation or opening of new facilities.
And how about scope of practice, Mitch? So you've done research on this.
Yeah, scope of practice is these rules and regulations delineating what different health professionals can do. And my research is about nurse practitioners. Some states have very strict rules on what nurse practitioners can do by themselves. Other states let nurse practitioners practice independently, what we call full scope of practice.
No.
And the rules are designed to sound like they're safety enhancing, and sometimes they are, and sometimes they are to protect special interests.
So, and we'll get much into these in a little bit, but one problem Alabama does have that I think is pretty widely recognized is we have a healthcare shortage, healthcare practitioner shortage. This is a map showing the counties in Alabama, and there's actually supposed to be white on this map. Any county that didn't have any healthcare professional shortage would be colored in white, and you see that no counties in Alabama are colored in white. A few of them are in the light blue, which is sort of showing a moderate level of shortage, and then dark blue is a shortage throughout the county. So we do have a problem here, right? This is a shortage of healthcare.
Oh yeah, it's a real shortage. So Alabama has 127 designated health professional shortage areas. So a health professional shortage area is an area where there's less than one doctor per 3,500 patients, or for some reason the patients are extra sick or extra poor, then you need one doctor per 3,000. If you don't have that, you have what's called a health professional shortage. In Alabama, over 2.7 million people are affected by that. And you would need in Alabama another 349 physicians to even come close to solving. And that would give you the bare minimum. If you had another 349 primary care physicians, that would get you at the bare minimum.
Also be assuming that they'd want to go live in these areas where we need them.
They would have to want to live in the areas. And that's often the dilemma, is that you don't have enough physicians, but also that physicians don't want to live in some of these rural areas. Mm-hmm. You just can't attract them.
Yeah.
And the only way to get healthcare providers spreading out into these more rural areas is to expand supply, and that usually means nurse practitioners.
Now, both of these laws are established by states. And that means from an economic standpoint, if you're an economics researcher, you get very excited when you hear that. So like, Macy, if you could tell us, why is it so great from a research perspective that these laws are established at the state level, and that not all states have all of these regulations?
Well, again, like you sort of hinted at there, economists love variation, right? So we want to see differences across states. We want to see states that have programs, states that don't have programs. And so in terms of certificate of need, there, I think, are 35 states in DC operate some sort of con program, so that leaves a handful that don't. And that lets us as researchers sort of examine the health outcomes across these different states. And like you mentioned, the programs cover different facilities and different capital expenditures as well. So this allows sort of for good research, we can see, oh, what is this state doing versus another state? How can we improve, and how can we try to make healthcare more accessible to these rural patients?
All right, so now let's dive a little deeper into both of these types of regulations. We'll start with the con regulations. So I was actually interested in a study that you did, co-authored with Dr. Smith, Macy, that these regulations actually go back to the 1970s, or at least nationwide. And tell us a little bit about that, and then also tell us a little bit about what do people think that these regulations are going to accomplish for the good?
Yeah, so again, you're right. This started in the mid-70s, I think 1974. There was a federal mandate that required all states to open sort of a health planning agency. So some states sort of retain that name, and that's what they'll be called now, and they won't necessarily call themselves con or con laws. A lot of them, I think even in the case of Alabama, it's called the State Health Planning Development Agency. So not necessarily a con program, but it is a con program in disguise. And what happened is the federal government implemented this mandate across all the states. Sometime in the 80s, the federal mandate was actually repealed. And again, it's hard to find sort of politicians don't want to come out and say explicitly, this is why we repealed this program, but I think it's safe to say it probably wasn't very effective. And then in mid 80s, you had states had the choice, right? They could keep the program, they could repeal these con programs along with the federal mandate repeal. And so we saw some, like I mentioned before, variation take place in the 1980s. So some states completely repealed their con programs, states like California, Texas, Pennsylvania. Other states decided to keep their con programs like Tennessee and Alabama. And then some states like Tennessee and Alabama actually just decided to expand what facilities are covered under these laws.
And it actually turns out, I mean, I think there's something on the order of about 36 or so different types of different facilities that could be covered by this. And so it varies from state to state. When we say like states are a con state, they actually could have anywhere, as long as they have at least one, they sort of fall in that heading. But I think something like the one with the most has about 37 or so different things, right?
Yes, that's true. I believe it's Hawaii has the most facilities and actions. So the con breaks two things apart. So sometimes they're speaking about facility requirements. Mm-hmm. You're not able to open a hospital. And then additionally, there's actions that require approval as well, being we want to expand beds, we want to invest into this new medical technology. So the restriction's actually two-part. And so like you said, it sort of varies, right? Tennessee has, where I'm at now, has I think a couple more, maybe 4 or 5 more different facilities that they regulate compared to Alabama. But I think Alabama's was 17 or so different types of facilities. And right, these range from hospitals to drug abuse facilities, mm-hmm. And all sorts of different actions within these facilities.
And so then, on the one hand, the thought is that if you have these medical professionals, and actually the certificate need model can actually be applied in other industries and not just medicine. But the idea is that if you have professionals in the industry, they might be able to judge what facilities would be necessary and then what might be unnecessary. And if they don't approve the unnecessary ones, then we don't end up having to pay for them. It might end up driving costs higher. But it seems like there's a obvious problem with that, and that is if you give people who are already in the industry the ability to veto their people entering the industry, that's going to cause a problem, right?
Yeah, 100%. So, and what's important, I think, to recognize is in the 70s, the issue and the reason this federal mandate came about was trying to limit this excess spending. And the source of the excess spending was actually due to the insurance incentives at the time. So we functioned on, or the hospitals functioned on a cost plus reimbursement. So any health facility, any cost that they incur, they would get reimbursed through insurance plus some on top, I think around 10%. And sort of as the insurance, as insurance sort of fixed or changed to a fixed cost structure and started adopting, like we see now today, there's codes and there's certain universal refunds that are done on behalf of insurance, and it's not this arbitrary whatever you cost you incur plus 10%. That original reason for con is sort of evaporated, right? And now we see there's 3 new modern claims as to what con programs allow for, and this is going to be higher quality facilities, increased access to care, and lower prices, right? And we can get into the specifics later. But that's kind of what's going on. Is originally there was this perverse incentive, and we've seen it sort of change over time, and it sort of questions why are these con programs still operating?
Okay, so then let's turn to Mitch here and the scope of practice. And again, this is we're talking about within the healthcare context, but it's a type of regulation that also gets applied elsewhere. I think in the field of dentistry, whether dental hygienists are allowed to clean teeth on their own or not is also related to the scope of practice. So just in case, you could sometimes hear these actual types of regulations talked about in other contexts. But we are in the healthcare context. What's sort of the rationale for scope of practice?
So the idea behind scope of practice, the public, the idea that it's a good law, the way that it's sold by proponents, is always that this will protect patients. And the reason is that physicians have more training than nurse practitioners. So let's go through that. Nurse practitioners have a bachelor's degree and an RN. They have to be registered nurses as well as nurse practitioners. Then they go to graduate school in nursing. They take 2 to 3 years of graduate courses plus clinical hours. Physicians have an undergraduate degree, then they go to med school for 4 years, then they do their residency. That's where physicians really learn to be physicians, is in their residency. Then they may or may not do a fellowship, kind of depending on what their specialty is. But for primary care, they do their residency normally. So they have more training. It would seem like the more training would lead to being better healthcare providers. What we see in the evidence is that they're about the same. And I don't really care how hard you worked. What I care about is how good you are. I want to measure the output of healthcare, not the input of how hard you worked to get to become a provider. And that's really hard for people to understand, is that physicians worked harder to become providers, but then they don't seem to provide primary care any better than nurse practitioners. And there's even some randomized control trials about that, where they compare nurse practitioners to physicians in primary care, and the results are the same.
So yeah, we can talk some more about that. But one of the issues is, like, with if we're going to try to rely on physicians, is that you mentioned that we might need an extra 350 general practitioner physicians here in Alabama. But one problem is that the supply of, or the number of doctors, medical doctors, hasn't been increasing very much. But by contrast, nurse practitioners have been increasing pretty dramatically, right?
Yeah, the number of nurse practitioners in the last 12 years has more than doubled. And that's really impressive. That's really impressive. Like, they're just spreading out everywhere. And I think that makes physicians nervous. But the scope of practice regulation means that those nurse practitioners, when they want to spread out everywhere, can't, because they have to work either under the supervision, or sometimes it's called the collaboration, of a physician. So that means a physician is overseeing them, and that makes it harder for them to move out. Um, and sometimes nurse practitioners will set up on their own under a collaborative practice agreement, where the physician is theoretically overseeing them. But physicians charge for that, and they
Yeah.
charge between $500 and $1,500 per month. And if you think about a small business paying an extra $500 to $1,500 per month, that's a lot of money. That's just a tremendous amount of money. And it really means you could never go somewhere where most of your patients are on Medicaid or Medicare. Medicaid just doesn't reimburse well. Reimburse is the fancy health word for how much you get paid for each procedure you do. And Medicaid pays very little. And so you could never have a practitioner go to a poor rural area where a lot of people are on Medicaid if they also have to pay this additional fee.
Oh. All right, so
But yeah, that's what the scope of practice rules are in Alabama, that nurse practitioners have to be supervised by a physician.
So let's turn now a little bit, because we have this variation across states. Economists need to publish, and they want to publish. They can take advantage of this and investigate. So, Macy, start with tell us a little bit about some of the findings from this research having to do with the certificate of need rules.
Yeah, so most of the research that's done focuses on the three goals, right? I think that's the best way to sort of analyze whether something's fulfilling what it's designed to do, right? So we want higher quality, we want lower prices, and we want especially rural access or increased access overall. Most of the research, and there are a few studies that find that con programs are effective in doing some of their goals, but most of the overwhelming body of research points to actually lower quality healthcare at increased costs and no real effect for rural residents, right? So I think if any policy has either no effect or a negative effect, people would sort of maybe want to step back and question what is this policy achieving, if anything. And the way that they look at this is multiple ways. So there's just general, does it limit expenditure? And so the studies that do find that it does limit hospital investment or expenditure, it's what you would expect to find, right? So if you make the process of expanding beds or investing in medical care or medical equipment, you make it more tedious and a long, drawn-out process, you would expect to see less investment. So on that front, it's no surprise. But the question is, does this really lead to higher quality and increased access? And the research just really doesn't show that that's the case.
So tell us, elaborate a little bit for our listeners, because you mentioned about how it is, there's lots of studies done, and a few of them show that sometimes occasionally that certificate of need laws might be accomplishing these goals, but the majority of them don't. So how do we sort of make sense of this? Is it just a matter of like, oh, well, he said, she said, or how do we make sense of this, and what does it mean when you see some results across different things? Does it mean we can't really learn anything, or what?
No, I think naturally there's going to be disagreement, right? And because I think there's going to be variation across how many services, I don't think that you can argue that in Tennessee, one of the facilities that is regulated is burn centers.
Okay.
I think there's only 2 in the whole state. But so you got to take some of these results with a grain of salt, because you have to imagine that a standalone burn center operates a little differently than maybe a full general hospital, right? So, and that can explain why researchers may look at different things. They may look at different measures, right? And they may have a certain rationale as to why, oh, well, this measure or this hospital that deals exclusively with Medicaid patients has different results than this other hospital that deals with a different kind of patient base. But I think it can be confusing at times, but I think time is ultimately on our side as more and more researchers dig into it. And in that policy study that Dr. Smith and I wrote that you showed here at the beginning, we go through service by service every single study and try to, summarize the results the best we can. And there's very little dissenting evidence, right? There's 2 or 3 papers here or there, but overwhelming evidence for lack of quality, higher prices, and no real effect on access. Actually, in some cases, patients even driving out of state to a non-con state in order to receive healthcare.
Okay, so then let's turn to Dr. Mitchell. Tell us a little bit about this research, because you mentioned that there's been some randomized control trials, which tell us a little bit about what that involves, because in the healthcare field, that's like the gold standard of research. When you can do that's really, that's the top of the line.
So, I mean, there's a study, it's in JAMA, it's the journal you've heard of, it's in JAMA, it's in 2000, right? So this is an old paper, it's paper that we've known about for a long time. And they take the people coming in who need primary care, and they just randomly assign them to physicians or NPs, and they get the same result.
Awesome.
Hmm?
Go ahead.
Say it again?
Go ahead.
Oh, okay. Yeah, I mean, I guess a physician theoretically could say, well, they did take the absolute sickest people and who didn't need primary care, who need something beyond primary care, and give them to physicians. And I would say, yeah, nurse practitioners specialize in primary care mostly.
Right.
That's what they do. And so when you compare nurse practitioners to physicians who do primary care, nurse practitioners do a great job. I don't really know why you would compare them to people who don't do primary care. That would be kind of weird.
Yeah.
That would be like comparing economists to theater professors and whether or not we were good at doing theater. That would be strange.
Yeah.
But when you compare nurse practitioners to primary care physicians, nurse practitioners do a great job. And when you let nurse practitioners do work, we get a lot of stuff. So one, there's a paper by Schnell. Oh, crikey, I'm blanking on her name. There's some research looking at what happens when nurse practitioners can provide prescriptions for anxiety and depression. Suicide goes down. That sounds like a good thing to me. My own work is on primary care. I look at diabetic debridement. So diabetes is very common, and Alabama's got a lot of it. And those counties that you looked at where there's not enough health professionals to go around, those are places that have a lot of diabetes. And so we looked at diabetic debridement because it's something that shows that your diabetes was not treated properly. Ideally, your diabetes is taken care of and you don't need debridement. Debridement is when they have to scrape like the dead and dying skin off of your feet usually. Nurse practitioners don't do that. It's normally podiatrists. It is one of those things that makes you, as an economist, very glad that you don't have to touch people, that we're not actually in health. But we found that when states changed their laws, that people in rural counties got their diabetes treated better by not needing diabetic debridement the following year. And it wasn't that nurse practitioners suddenly opening up new clinics all over the rural areas. It's that the scope of practice rules where they have to be supervised by physicians is actually very time consuming. And if you think about it, if a nurse practitioner spends a couple of hours each week getting permission to do various treatments from physicians, that means the physician's not seeing a patient and the nurse practitioner is not seeing a patient. So we didn't see anything in urban areas, but in rural areas where there's so few providers, just having an extra hour a week made a huge difference. We saw a dramatic drop in the number of debridements that people needed in rural counties in the states that did it. And that was the immediate effect. That wasn't a chance to sort of say, hey, now that we've done this, can we attract new nurse practitioners? Can we get nurse practitioners to open up new clinics? Can we get nurse practitioners to start thinking about working more hours than they already do? This was just the immediate, quick, down and dirty impact. And it's really impressive that people got their diabetes treated better.
Well, that's awesome to hear. Now, let's think overall. So we've seen that the evidence shows that these regulations don't work so well. They certainly don't work as advertised. When it comes to possibly thinking about deregulating or eliminating these regulations here in Alabama, how much of a benefit might we possibly be seeing here? So, I mean, Macy, you mentioned that the costs are a little bit higher. Well, like about how much higher? What are we talking about here? A little bit or a lot, or what are we looking at?
Yeah, so Mercatus does a lot of work on certificate of need, and they specifically about Alabama. And they estimated that if Alabama did a full repeal of their con program, the per capita savings would be about $200 a year, which is pretty sizable. And they also estimated that they would go from 41 rural hospitals up to 58. So that would be an increase of 17 rural hospitals that they don't have now.
Well, and it's important to think about that because, I mean, that's shorter, that's shorter trips to the hospital, that's shorter ambulance rides in the time of an emergency. And, so not just like the care there, but there is also a lot of extra burdens on consumers the farther you have to go to get treatment, right?
Yeah, and that's only half of the story, right? Up until this point, we've only been thinking about the patient or the consumer. But these laws affect workers as well, right? They affect nurse practitioners, they affect doctors, they affect all of these people. And think about the kind of jobs that come with 17 additional hospitals, right? You have nurses, you have staff, you have people working in the cafeteria, you have tons of room for growth. And I think that's also the other side of the coin that a lot of people don't think about is by restricting access, you're also making it harder for these nurses to find competitive wages or doctors to find competitive wages across these different surgical centers or hospitals.
Yeah, because after all, it is competition between different businesses that we believe bids people's salaries and wages up to the level that their productivity allows them to be paid. So that's an important consideration. And then, I mean, there's also the element from economic development in rural areas. If your county, if your area doesn't have a hospital or medical center, then I mean that's just another strike against you when it comes to trying to recruit or retain businesses. I'm sure it's got to be very high up on the list of like how close is the nearest hospital if you're thinking about locating a business somewhere, right?
Yeah, 100%. And that is kind of where these two sort of laws come hand to hand, right? Scope of practice and con. Is naturally why they're in an episode here together, because con sort of is the regulation surrounding how can you establish medical facilities, and then to Dr. Mitchell's point, scope of practice laws are really speaking to what are these people in these facilities able to do, and both of those need to be addressed in order to ensure we have really good rural access to healthcare.
And it's important to point out here is like this is not, we could achieve these two forms of deregulation without spending more taxpayer dollar on this. I mean, usually when you're talking about improving healthcare, improving anything else, and you're talking about the government doing it, it's usually like, okay, how big of a check do you have to write from the Treasury to make these good things happen? But this wouldn't actually cost us anything off the budget, right?
Yeah, no, 100%.
Dan, I think one of the things that's really exciting is, a big part of every state budget is the Medicaid part of budgets, right? It's just a big chunk. It's like $7 billion in Alabama. So nurse practitioners save you money in two different ways. One, they make less money. They actually earn less money. They get reimbursed at a lower rate than physicians do. So that is pushing prices down. Shifting the supply curve out is pushing prices down. So there's that sort of shifting the supply curve out with lower cost things is pushing prices down. The other thing that's happening is you're getting things taken care of quickly early on when it's cheaper. It's always cheaper to deal with things early than it is late. If you have diabetes, it's cheaper to see a primary care provider and get that taken care of early than it is late, because late means you have diabetic blindness and diabetic nephropathy and you're getting like amputations. It's all terrible. So there's a range of estimates about how much just the prices would come down, not the savings on getting things done early as opposed to late, but just pushing prices down. So if you take the most conservative estimate what the prices coming down would be is 3%. You say, well, that doesn't sound like very much money. Then you remember that Alabama spends about $7 billion on Medicaid. So you think, well, 3% of that, if that price could come down 3%, that's $21 million. $21 million here, $21 million there. Dan, before you know it, you've got real money in a state budget.
Yeah,
I can't help but think, okay, if you guys save $21 million a year, if you save $21 million a year, what could you do with it? Well, first you could give it back to the taxpayers. Second, you could do education. You could do all kinds of things, like $21 million a year. That's a lot.
Well, thanks very much, both of you, for coming on and talk about this. We appreciate it very much. And thank you all for joining us. Join us again next time for another EconVersations.
This has been EconVersations, a joint production of Troy Trojan Vision and the Manuel H. Johnson Center for Political Economy.